take care of that. Post-COVID hospitals are coming up. So the point is we are going to live with COVID, and the webinars like this will enable us to live with COVID. And here I congratulate Dr. Joy and Pavan Madhusudan for organizing so many webinars with the support of Indudharan and other team. You are doing a wonderful job, because the only weapon with which we can survive is knowledge. And that is the only weapon. And we are creating knowledge through these webinars, and we will try to survive. We will, definitely we will survive, and we will protect life. At the same time, we will protect livelihood also. By lockdown, we could save life, but then livelihood could not be protected. Now, life will be saved, livelihood will be saved, and we will live with COVID. And one day, a magic drug will come. One day, someday. We don't be hopeful that next month somebody in Kochi is discovering a new drug. These are all nice things. Let it come. But till then, find out a way to survive with COVID. And I congratulate once again IMA, and my friend Syamsunder is moderating it. I'm so happy about it. With these few words, I declare this session inaugurated. Thank you. Thank you very much.
Thank you, Dr. Mohanan, Vice Chancellor. Now over to Dr. Indudharan for his address, Chairman's address.
Hi. Good evening, everybody. Respected President of IMA THRISSUR, Dr. Joy, Secretary Dr. Pavan, senior colleagues and friends. It has become a great pleasure to host this event, the most wanted scientific session of the present day. It is a great opportunity for us to listen from experienced experts in this field at a time when we doctors ourselves are most confused about how to go about primary care and get trained in the care. Probably most of us know how to treat the aftermath of COVID, but the crux of the management must be prevention, considering the rapid spread of this disease. I hope this program will help us to have a clear vision about the prevention of COVID, or rather self-protection of ourselves from COVID. I welcome our dear Dr. K. Mohanan, the respectful Vice Chancellor of Kerala University of Health Sciences, State Secretary of IMA, and my colleague and friend, Dr. Gopikumar, who is at the helm of COVID preventive affairs of the doctor community, Dr. Sabu Varghese of Brookdale University Medical Center, New York, Dr. Jacob K. Professor of Medicine, Government Medical College, Kochi, and my former colleague, moderated by Dr. Syamsunder, Consultant in Medicine, Government Hospital, Trivandrum, and all the esteemed participants of this meeting. I hope to have a good scientific preventive session. I am made to understand that protection will be highlighted, protection of us will be highlighted in this session. Dear friends, welcome all of you. I'm Indu here, the Association of Medical Specialties Chairman. Once again, welcome all of you.
Thank you, Dr. Indudharan.
Thank you.
Now, Dr. Samuel Koshi, welcome to this webinar. And now I invite our State Secretary, Dr. P Gopikumar, his address, and for the inaugural and for the release of our e-magazine, MASHIPOORAM. Over to you, Dr. Gopikumar.
Hey, good evening, respected President of IMA THRISSUR, Dr. Joy, Secretary Pavan, IMA AMS THRISSUR Chairman Dr. Indudharan, and Secretary Dr. Unni, Chief Guest and our own member, Honorable Vice Chancellor Dr. K. Mohanan, State Vice President Dr. Samuel Koshi, State Joint Secretary Dr. Jain Chimmen, esteemed faculty Dr. Sabu, Dr. Jacob K. and a good friend Dr. Syamsunder, past presidents Dr. Devdas, senior leader Dr. Srivilasan, friends and members of Indian Medical Association Thrissur branch, and even Dr. Roy has joined. Many more faces from all over Kerala has joined. The number is 144 participants at present. Well, I'm very happy to be here attending this IMA AMS webinar again on COVID. Of course, the webinars are on COVID and COVID only. Now, as our Vice Chancellor, Dr. Mohan has mentioned, now we have to live with COVID. And as Dr. Indudaran has mentioned, we have to protect ourselves. So my point will be the stress on protecting the healthcare workers, our own protection, the doctors and the staff nurses, because at present we see a lot of cluster formations, especially in Thrissur, in many of the private hospitals. Now that the cases have reached the private hospital for management, earlier it was in the government sector, government hospital, that COVID patients were being treated. Now, at least we see in 3 or 4 hospitals a cluster formation in Thrissur. So there lies probably the laxity from our part, the doctors and the staff nurses and other healthcare workers. The laxity or probably is the main cause of getting infected with COVID. So definitely that will be the stress to be given to have fully protected, in a fully protected manner, you have to see the patients and deal with the patients. So that will be the single message I have to give to you from the Indian Medical Association state branch. Because at present, we are stressing on that particular point. We are providing the equipments needed, including the N95 masks or infection control items and PPE kits, so on and so forth. So it's very, very important. So my request to all of you, protect yourself and work in the COVID scenario. And now, Indian Medical Association Thrissur branch is coming out with an e-magazine. Of course, from the very beginning, Dr. Joy was planning to bring out a magazine in the print form, but now things have changed. Of course, COVID is teaching us a lot of changes in our way of life and everything. So even the IMA newsletter of IMA Kerala State branch is in e-form now. We are not printing it. So again, we are coming out with an e-magazine. Thrissൂരിന്റെ പ്രത്യേകതയായി ഒരു മഷിപ്പൂരം. ഒരു പക്ഷേ അതിനകത്തെ കണ്ടന്റ് ഞാൻ കണ്ടിട്ടില്ല, എങ്കിൽ പോലും കേട്ടറിവ് വെച്ചുകൊണ്ട് തീർച്ചയായും അതൊരു തൃശ്ശൂർ പൂരത്തിന്റെ എഫക്റ്റ് തന്നെ ഉണ്ടാക്കുമെന്ന് ഞാൻ വിശ്വസിക്കുന്നു. അതിന് നേതൃത്വം നൽകിയ ഡോക്ടർ ജോയ് പവൻ എന്നിവരോടും അതിന്റെ എഡിറ്റോറിയൽ സെക്ഷൻ ചെയ്തിട്ടുള്ള ഡോക്ടർ അരുൺ, എല്ലാവരെയും ഞാൻ അഭിനന്ദിക്കുന്നു. തീർച്ചയായും റെഗുലറായിട്ട് നമുക്ക് ബ്രാഞ്ചിനെ സംബന്ധിച്ചിടത്തോളം റെഗുലറായിട്ടുള്ള ന്യൂസ് ലെറ്റർ വേണം എന്നുള്ള ഒരു ഇതുണ്ട്. അപ്പൊ അതുകൊണ്ട് തന്നെ അത് റെഗുലറായിട്ട് പബ്ലിഷ് ചെയ്യുന്നതിന് ഇപ്പൊ ഈ കൊല്ലത്തിൽ ഒരുപക്ഷെ ഈ കോവിഡുമായിട്ട് ബന്ധപ്പെട്ട് നമുക്ക് സാധിച്ചില്ല എങ്കിൽ പോലും there should be a regular publication of every branch. That is the norm. So with നിങ്ങളുടെ എല്ലാവരുടെയും അനുവാദത്തോടു കൂടി ഇതിന്റെ പിന്നിൽ പ്രവർത്തിച്ച എല്ലാവരെയും അഭിനന്ദനങ്ങൾ അറിയിച്ചുകൊണ്ട് വളരെ അഭിമാനത്തോടു കൂടി ഞാൻ ഈ മാഗസിൻ മഷിപ്പൂരം എന്ന ഈ മാഗസിൻ നിങ്ങൾക്ക് എല്ലാവർക്കുമായി സമർപ്പിക്കുന്നു. അത് ഇപ്പോ അരുൺ will just launch that e-magazine. അതിന്റെ കവറാണ്. This is the excellent magazine. So you can go through it. We will just upload the soft copy in the WhatsApp groups and email. So with that, I conclude my words. Thank you once again to the IMA Thrissur branch. Thank you. JIMA Jai Hind.
Thank you, Dr. Gopikumar. ഈ മഷിപ്പൂരം എന്നുള്ള പേര് കോയിൻ ചെയ്തു തന്നത് മുൻ പാസ്റ്റ് സ്റ്റേറ്റ് പ്രസിഡന്റ് ഡോക്ടർ VG പ്രദീപ് കുമാർ ആണ്. And ഈ സമയത്തിൽ I take this occasion to thank him for his caption. Thank you, Dr. V.G. Pradeep Kumar. I don't know whether he is around. He told me he will come in the webinar. Dr. Pradeep Kumar, are you there? Then we will move on to the State Joint Secretary's address, Dr. Jain Chimmen. Over to you, Dr. Jain.
Thank you, Joy, sir. Hope I am audible.
Yeah.
Okay. So let me congratulate Thrissur branch once again for the excellent way they are going about in during the COVID times. I think this is the second international webinar that they are conducting now. And today we have got third international. So Thrissur IMA has gone international. Very good. So it's a hat trick now. So congratulate once again for the team for coming out excellently this way. We have a very good academic section to be followed. And as State Secretary said, and on the threshold of Kerala being on the threshold of crossing 1 lakh COVID positive cases, I think this time that we should not be lax at all. We should each and every COVID seminars are giving us newer knowledge, because as we know, COVID is a relatively new disease. So every day we are learning about it. So you should make it a point to attend all the seminars or the webinars or all Zoom meetings that is possible on webinars. And along with protecting ourselves, we should make it a point that we protect our staff who are working with us, our colleagues who are working with us. If our staff and our colleagues are protected, then only we will be 100% protected. So with this message, take home messages, learn more things about COVID, see that you are protected, and make sure that who are around you, your staff, your family, are all protected. So let's and Mohan sir, it's good to see you at least in a webinar. It's a long time since we met in person. So once again, wishing all the success. Thank you. Bye.
Thank you. Now we will go to the scientific section. Before that, I invite our AMS convener, Dr. Unni R. Baby, to introduce the faculties and the moderator. Over to you, Dr. Unni.
Thank you, Joy sir. Good evening to one and all. Good evening to all office bearers of IMA, senior members of IMA, and my friends. The duty for me is to introduce the speakers. The session AMS has been trying to have a webinar on a practical aspects of COVID management. Before we had a international speaker and a speaker from Kerala, Doctor from Kerala, on a first session, which was a critical care management. Now we have a session on primary care management of category A and B patients. For this, we have a moderator, eminent senior consultant in medicine and general hospital Trivandrum, Dr. Syamsunder OS, who will be moderating the session. He has been past president of KG MOA and also vice president of IMA Trivandrum. He has also been a DNB coordinator in general medicine and general hospital Trivandrum for the last 9 to 10 years. I welcome you, sir. Welcome to this webinar. We have two speakers. One is Dr. Jacob K. Jacob, who is a professor internal medicine at General GMC Ernakulam, Government Medical College Ernakulam. He is a unit chief and COVID treating team of at GMC Ernakulam. He has been one of the front runners in running the center at Ernakulam Government Medical College. I welcome you, sir. Also, our next speaker is a speaker from New York. He is Dr. Sabu K Varghese, who is a attending hospital at Brookdale University Hospital, and also he is working at New York Primary Care Physcian at QNCPC, New Hyde Park, New York. I welcome you, Dr. Sabu K Varghese. Over to the moderator and the speakers. Thank you.
Hello. Now, I invite Dr. Sabu Varghese for his talk, first talk. Over to you, Dr. Sabu Varghese.
Okay. Thank you, Thrissur IMA, respected Chief Guest Dr. K. Mohan, President Dr. Joy Manila, Dr. Inturam R, Dr. Pavan Madhusudan Secretary, Dr. Unnibi, for giving me a chance to speak in this platform. So I'm so humbled to see all my professors here. First of all, I'm going to tell that, I just want to, give my experience. I'm not a super expert on this. I know there are people in this panel probably know better than me about COVID, and everything now, because, I know the standard of doctors in all medical schools in Kerala. Let me introduce myself. I graduated from TD Medical College, Alappuzha, and I moved to New York in 2010. And I did my residency in one of the residency program in New York City. And then I joined one of the teaching program in Brooklyn. And now I started a primary care practice in 2012 in Long Island, which is a suburb of New York. And and my wife is also a doctor, Blessy Mary Joseph. She also works with me in the same place where she's also a primary care physician. So let me start with COVID-19, my experience. Initially, I also thought COVID-19 was, it's in China. So I didn't care. I never thought it's going to come to New York, or maybe, as everybody thinking here, we are all safe, and we are, just seeing some seeds in Facebook. But it all started all of a sudden. Can everyone hear me? Can you hear me?
Yeah, we can hear you.
Okay, thank you. So, okay. So in March first week, that's where the drama started in New York all of a sudden. So I remember my first day, where I was, I usually take 3, 12-hour calls in my teaching program. Remaining time I am in primary care practice. So when I went there, I saw only one patient, in first week of March. And everyone was so excited to see that patient. Oh, this is suspected COVID, so many, residents were excited. So they thought this is going to be only one case for, so everyone, like as usual, academics, they were all excited talking about all comparing to Chinese studies and stuff. And the next day we got 3 patients. I remember, Tuesday was the call, Wednesday I got 3. And the next day I got 7 calls. So 7 patients. So I thought, I left that week, that's that where I was. Then next week, hello. So the next week when I went there, after a week, that means the March 2nd week, while I was parking my car in the garage, there was this, some kind of smell, I was feeling. So I was wondering what kind of smell is this? And so I asked one of the resident coming out exhausted, and so I asked her, what is this smell? So he showed me 3 trucks in the basement of my garage, like where we park cars. There are 3 trucks, and the bodies were waiting to be loaded. So when I saw that, I was so terrified. What is this? What is it? We've never seen something like this. And when I entered into the hospitals, and when it's like to the ER, there are more than 100 patients and 60 patients on ventilator, and it's like a chaos. Nobody know what to do, and people were sitting in chairs and on the corridors and everywhere, and there are courts every half an hour. So every 30 minutes, the residents are running that way, this way. So everything is COVID. And I also, my colleagues already got sick, and 3 of the ICU attendings were sick with COVID and were admitted in another hospital. They moved. And one of my 2 friends were also intubated, like the daytime attendings. I worked in the nighttime. So it was so my point is that this is not a hoax. There is some people say that I see in Facebooks and somewhere, oh, this is only 1% mortality case. This is there is nothing to be fear about this. Absolutely not. It's when you see such a scenario, only people understand with the magnitude, because it kill the patient at the same time it kill the provider. Like it's like you're going to take a snake or something, like the snake bite back, you also dead, that kind of job. It's like you have to be very cautious dealing with this virus. So I will stop there. I don't want to talk more about that. So then I recognized there are people from my community start dying. I saw my friends from my organization, a couple of people got sick and intubated, and people start calling me, and the New York shut down. So they, they immediately stopped all the primary care like us. There's only certain places, testing was available, and most of the doctors, stopped working for primary care. But me and my wife decided to keep it open because first of all, it's for learning. Second thing, there is community was in so much need, so if we hide, what is the point, so so we kept open. So what we have to be cautious because it can kill us. So it's not that easy. So first of all, thank you for inviting me here, but I will give you statistics. I treated almost like a 1,200 to 1,300 patient outpatient. I want to give only the outpatient aspect because inpatient was totally different. So in outpatient settings, I treated 1,200 to 1,300 patients, and still I am yet to see a mortality, and there was 0 death. So that's where I am standing. So primary care. So first thing, I will give you my hello. So I will just start with how I did my primary care. What are the protocols I basically follow. So first of all is protection of my staff and myself. So that's a number one thing. So I used telemedicine. If this I can advise everybody, this disease can be purely managed by telemedicine or even phone. You don't need to be seeing the patient also. I know all the high standard of clinical taking history and the abilities of all the doctors in this panel. If primary care, anybody, this disease can be managed through the phone. So then you will ask, how will you manage through the phone? What I did. So first thing I did was I designed, I collect, there was a lab nearby. I got some, testing kits. First thing is to test the patient. That's what is the number one thing. So what I did was I designed this, like a swab, and put some marks on the swab, like in the middle. And I gave the patient, I kept it outside, of my clinic, and they can pick it up. And through the phone, through the telemedicine, I teach them how to swab at home. So they put, touching the nasopharynx back, and I told them to 5 seconds, just rotate, take it out, and through the other nose, one more time, 5 seconds, rotate for 5 seconds. This is more than enough. This virus is so contagious. That swab is going to be positive if it is COVID. There's no doubt about that, because this disease is so contagious. Even if somebody passes nearby, you get COVID. So it's like, you don't need to be, doctors or somebody trained has to do to the swab. So I started swabbing, like self-swabbing, designed that self-swabbing kit. So, and I gave it to the patient, and they swabbed it. Usually I get within 48 hours the results. So let's, before starting the management, which I did, just tell me, then I'm going to give you some aspect, and everybody knows what is the preventive aspect is the main thing in this virus, because I still believe this virus is more severe if there is patients who get more viral load. That was my principle, one of my understanding. I'm not sure, there's virology expert has to say that. If you get more virus, definitely you get more severe disease. So prevention, starting from the beginning, like wearing a mask, social distancing, avoiding crowds, and and we are, the infected patients also wearing a mask and not giving that much virus to other guys. So in that way, if the viral load is less, whoever getting that virus, may not have a serious illness. So the disease definitely depend upon the number of viral particles people inhale. And other thing is, I noticed why, because in my practice, more obese patients or how I say obstructive sleep apnea, or who has who breathe through their mouth, has more severe infection. So it's like an observation I noticed, because a lot of people, short, stouty, breathing through the mouth, not using CPAP machines for obstructive sleep apnea, those kind of patients are immediately crashing. So then I recognize, okay, probably they are inhaling this virus through the mouth. It's not going through the nasopharynx route. So That also shows that this virus goes directly into the lung and cause a different disease than if it could go through the nasopharynx. That's why all the protective gears. I am still negative. I never got COVID, even in inpatient and outpatient. So we can trust PPE. That's my advice to you. PPE will protect everybody. In initial part of the phase, New York a lot of doctors hit because they were not using PPE because nobody advised them to do so, because everyone thought, okay, in ICU and stuff, they were just wearing simple mask or, like not even, they were not like taking caution. So PPE, proper N95 or, the face shield, 99% of the burn, you are protected. So that's number one. Try to avoid, primary care, as I told you, there is no need to interact with the patients for, mild to moderate case. You can definitely manage this through my, whatever I said, like, so, design a kit so that patients can swab at home, bring it back. I kept a box outside there, drop it back in my office, and the lab collect. I never interacted for that testing for purpose. So the lab comes and takes it, and I get the result within 48 hours. So I was able to do that. So patients were also satisfied. Everybody, all the home, everybody I swabbed. So that's where I tested. So regarding the management, as I said, so first thing is the clinical evaluation. So, you have to take a history, basically, we start with the history. Yes? So everybody knows about the symptoms now. I don't have to explain all the symptoms. Basically, I categorize patients into two categories, when they initially call me. So this disease is time dependent. So it's 1 to 14 days. We just, we start, if you put the first day, like as you get a virus, usually you are symptomatic by 4th day. So that 4 days after period, you start spiking fevers. And that's the 4th day is the time people call me. So that's where I noticed the people, calling 4th day has, I categorize into two. So there are two types of categories. One patient's, mild symptoms, very mild symptoms. They just have one episode of fever, like youngsters, particularly, less than 50-year-old woman, very safe. I never seen like, the woman has any problems. I don't know. Men has problems, and, lean people, a lot of people, majority, like I'm telling you, almost 50% of the patients, like if you take, 1,000, like 50% of the patients have very mild symptoms. And those have just alterations, like taste, and they have, maybe one episode of diarrhea. These are the only things they have. So they have very mild symptoms. And the second category of patients were like little more moderate, those who have some risk factors, male over 50, and they start with the fever, very high fever. There's a difference between the fever of these two categories. The mild symptom patients, the fever may be a little less, but the other patients, the fever is high, like 103, 104, and then they start having like a chest tightness and dry cough. Those are other categories of patients, and they look a little more sicker. When you see through the telemedicine, you can see that they were sicker and anxious, and they say that their whole system, they can feel something inside the body. You understand? So what they're feeling most likely is because the virus is spreading through the vascular system. So it's like, everybody knows this virus attacks more vascular system than like a regular pneumonia or whatever. So it's like, so that's why they feel they're pulsatile or something, in their face, you can see that. So that's the moderate case. So initially you have mild cases, and there are some patients more moderate cases.
Dr. Sabu, unmute him. Unmute him, Dr. Sabu. Please unmute.
Yes. Yes, I unmute. Can you hear me?
Now we can hear you.
Okay. So basically there are two categories: mild symptoms, and outpatient. I saw there is other category was the moderate symptom patients. So the mild symptom patients, I treated with the vitamin C, vitamin D. Vitamin C, 1,000 milligram BID, and vitamin D, 5,000. I used to use 5,000 daily, and zinc. I used a zinc 50 to 75 milligram, and I told them to take Tylenol because they were not having fever, like even, they would just have mild chills or fever, and they were not even using Tylenol. And I also put them on a double antihistamine coverage, what is Benadryl plus famotidine, So, it's like typical what we do in a common cold in any part of the world. So it's like a simple, measures. About 50% of the patients, out of, if you take 100 patients, if you give this, in about 50%, the mild symptom contains, like it's all, almost 50% of the patients are mild population, and they all got better, and there is nothing to be done for these patients, and they're all safe. So the remaining, so after, so the remaining patients, the moderate patients, what I did was, so along with this, I think there is little alteration. When they have more sick, I added a little bit more vitamin C. So I gave them vitamin C 2000 2 times. If you want some reference, there is Math Plus protocol by a university. If you can Google it, you get that protocol. Where I was following the Math Plus hospital treatment protocol for COVID. EVA. Some of the doctors in this panel probably know that EVMS critical care COVID-19 management updates. So I was using some online resources and talking to friends. That's how it's there. And there is another doctor in New York who was also giving some guidelines to us. So vitamin C was, I gave 2000 BID, and vitamin D, I loaded them, moderate cases, I loaded them with 50,000. And then after that, you continue 5,000. Vitamin D, loading 5,000 for moderate cases, then 5,000 daily. And then vitamin C, 2000 BID. Then I added a Citromax to these patients, when they're calling. Fourth day, I'm talking about the fourth day, when they call, I send a Citromax to the prescription. What is the logic behind Citromax? People may, maybe some people may laugh, I don't know, even, I know that why you're treating a viral disease with Citromax. Because in my past experience, even in any common cold, if you give a Citromax, patients, everybody's seen that it's a response. And people, we used to care that it's an anti-inflammatory effect of the Citromax, and you're not supposed to give it because it increases antibiotic resistance. I understand. But in these situations, I used, because there's nothing else to use. So all the patients, when they have this dry cough developing, I gave Citromax. It's an anti-inflammatory effect. It has an if any pneumonia developing, it protects. And the third thing was like, it has some antiviral activity according to, certain journals, if you research, there is some antiviral activities. Now they are researching on it in, New York, like, some of the places, they are looking into that, So I gave Citromax to, all the patients with moderate symptoms, along with this vitamin C, vitamin D, zinc. So then, good hydration. I told them every half an hour, you have to drink like at least half cup or 1 cup of water. No matter, hydration is very important. Second thing is positions. Like you cannot sleep or lie down all the time. This virus is going to kill you if you just lie down all the time. I know it's tough, but and second, so good hydration. Third thing is like I also ask them to, if they're sleeping in the night, I ask them to sleep on a prone position. That it's everybody knows about that position. It's more advantage. So, and taking deep breath exercises, because taking deep breath opens your lungs and like keep you less anxious, because these patients are very anxious. And I also added an aspirin 325, then aspirin, low dose aspirin to continue, because this disease is attacking the vascular system. So we and platelets aggregation, to prevent, I treated like like an aspirin. 325 was given, then, and a Lipitor. I added a Lipitor also, 40 to 80 milligram, like 40 milligram is enough. So aspirin, Lipitor, and fish oil also. I told the patients to take fish oil, which is available in USA in different form, Vasipa, Lovasa, whatever, fish oil, standard dose. So these are all, to reduce the inflammation. So this is fourth day, I'm talking about patients with moderate symptoms. About 30% of the patients, in that category where I saw. So in that, the remaining patients, majority, most of them, responded to this treatment. I can tell you that, I don't know, it was, the next day they felt better, even after, so many patients, like about, majority, maybe 5% of the patients may progress to the next stage. So majority of the patients were better with this regime. So then, so I will tell you one more time what are the things is Tylenol. And Tylenol is very important. You have to control the fever. These patients spikes 104, 110, even 109. Wow, some of the patients were like so high fever. So what you have to do is you have to do like a pediatric kind of Tylenol magic. You have to do around the clock. Don't chase the fever. just give in front and control the fever so that, you know, their heart rate won't raise. You know, sometimes, you know, high fever can precipitate heart attack. So, you know, so that's why you have to control the symptoms. Then antihistamines both, you know, there is H1 Benadryl and famotidine, you know, H1 and H2 blockers, because H2 blocker also helps, you know, it has some antiviral activity. Now they are studying famotidine is helping. I don't know, at that time I was just using as an, you know, like control the symptoms. And then good hydration, then adding, you know, treating like a MI patient, you know, aspirin plus statin, you know, it helps. So these are the things, you know, in moderate case, on 4th day I start when the patient calls. So 5th day, the next day I get the swab results, about 99% sensitivity, you know, where I suspected COVID, you know, majority, it came back positive. There is no doubt about it. Everybody, self-swabbing works. You don't have to swab. You can design a self-swabbing kit and ask the patient to swab. That's most easy, you know, very easy. And patient doesn't have to come from home. So you can manage them at home. So that's, you know, my point. So then, okay. So these patients with moderate disease, mild disease, I just completely forgot about. So 50% of the patients are completely fine. You don't have to follow them. Among these moderate disease patients, you know, these patients, I follow them daily basis. So next day I call to the phone, or maybe, you know, if the iPhone we have with telemedia, how you're doing. So those patients responding to, you know, these regimes, I leave it there. But about, you know, like, you know, if we take 100 patients, I told you the 50% of the patients mild. Now that out of this remaining 50, about 30 patients responding to the CPAC, zinc, vitamin C, dehydration, these kind of regimes. And the remaining 20% patients, out of this 50, the last 50%, the remaining 20% of the patients, you know, they are not responding to ZPAC. They look more toxic because I believe they get more viral load. Another one thing is, I know all the patients are quarantined. So, you know, in self-isolation initially. Self-isolation is also a double-edged sword. So I may tell that. Why? Because when you isolate a patient in the, you know, in USA, usually basement or, you know, one of the room very, you know, far away from the family, they are sitting in a one room with closed environment, especially in the winter because the heat, and they are reinfecting themselves. I noticed that people are getting better and going back again. So, you know, getting better, you know, you can see that patients getting fine, but they reinfect because they're coughing in the environment and they're wearing masks and they're re-inhaling. I noticed. So I told them, you know, if you know, I go in the backyard or somewhere you sit, or open all the windows and ventilate the room, like put some fan and put the virus out, and don't wear a mask if you are sitting away from the family. Just use a towel so that you can cough and then wash it with it frequently. Don't just wear the mask and re-inhale all the virus again and again. That's where I think I noticed so many people get better and then go back. So that's, you know, that's very, I think somebody needs to do a study on that. That's where some isolation kills sometimes patients. It happened in hospitals also, you know, because sometimes it's late. So because not all rooms are negative pressure rooms. So it's, you know, the virus circulates and it's, you know, this virus is aerosol. So you can re-inhale the virus, you know, initially you got just mild disease and you're converting it into a moderate disease by isolating yourself in a room and re-inhaling all the particle again. So be careful in that. So if you know, any patient sick, you know, it's important to take away from the public, definitely, but in that setting, they should have freedom. So they should have, you know, air circulations, you know, don't re-inhale us, you know, it's very important. That's one point I want to make. So those patients not responding to this, you know, initial, you know, like a ZPAC, you know, zinc, vitamin C, vitamin D, you know, these kind of supporting measures, progression to the next stage, I added hydroxychloroquine at the time. I know that it's a very controversial drug. You know, it's USA, we were having very difficulty getting those drugs at the time. So, but I believed it. So one of the, you know, a couple of my friends used it and they said it's okay to use. And I'm not an expert on that. And a study still, you know, so inpatient, you know, we didn't see any improvement in mortality, but, you know, nobody was using that at the time outpatient. So my job is to prevent patients going, you know, into the hospital. So I know in the hospital, patients are dying every minute. So it's not a disease to treat there. It has to be treated outside. So I, you know, researched on that particular at that time, March. I'm talking about March, and I get some positive, you know, like you know, results from the, you know, journals and stuff. So I put them on 400 milligram hydroxychloroquine BID, the same dose, you know, in Kerala where they're using. So for then 100 milligram. Sorry, 200 milligram twice a day for 5 days, you know, so the same regime. So I added on top of this Zithromax zinc. Usually I added on 6th day. So if because I'm talking about in timeline, because that's very important. 4th day moderate disease, you know, I added a ZPAC zinc and everything though. 6th day, I put them on hydroxychloroquine. If they're not responding to, they look toxic. And if they, you see like their faces and their, another one thing is they cannot sleep in the night, because when they're more sick, they don't sleep. That's what most of the wives says. Most of the time I notice wives are completely fine. The husband is the one having problems. It's a male predominant disease, definitely. So, when you watch, in the night, whole night, he cannot sleep. He just sitting and, he's walking in the, room and, getting, that's another problem. So in some patients, I used melatonin because something wrong with circadian rhythm. So melatonin can be helpful to fix, the sleep in the night. Some patients don't sleep. I know it's anxiety or whatever they're feeling, but, it's mentioned in the Math Plus protocol. I'm talking about melatonin can be used. So 6th day, I added hydroxychloroquine to these patients. So we are talking about, the remaining 50% moderate disease patients. I added hydroxychloroquine on about 10% of only the patients, because the remaining 50%, about 35 to 40% improved with the Z-Pack only. I'm telling you, there is no need. So 90% of the patients are out now from my, list. So only now I'm dealing with 10% they were not responding to my initial regime. So but I didn't stop any of my initial regime. You always carry on that regime. Add so I do given on 6th day, and about very good results. I know the place, about, I'm telling you, 9 out of that 10%, 9% of the patient improved. So with hydroxychloroquine alone. So I'm telling you, with hydroxychloroquine, with the zinc and zithromax, about 98 to 99% of the patients are out from my list. So they were completely fine. They were, still has cough and pneumonia. Sometimes you have to continue a doxycycline for another week. I didn't continue Z-Pack once Z-Pack finished at 5th day. So I used doxycycline to support the next antibiotic. I always cover them with antibiotics. I never stopped. I know it's, there's controversy about that, but, it has, doxy also has an anti-inflammatory effect. So, yeah. So these patients, not responding to, so now we are in 6th day, almost 98% of my patients got cured, which goes according to the statistics. If you see, like, in Kerala and stuff, same thing. And so that the 2% or 1 to 2% of the patients progressed on these regimes were the problem. So what I did was, I still didn't send them to the, you have to believe me, I never sent anybody to, so far I didn't send, so that we were managing outpatient. So what I did was, I did the COVID labs on these patients, not responding. So everybody knows about now the COVID labs, CPs, like the, creatine, liver functions, blood counts, D-dimer, CRP, and ferritin. The D-dimer and CRP is the main key. You can see skyrocketed CRPs in these patients. He was surprised. Most of the labs I did was on 7th day. If the 6th day patients are, crashing on hydroxychloroquine, or 7th or 8th day, every day I evaluate. Maybe 8th day, 8th day or 9th day I usually, and also did an X-ray test, because this patient, we were able to do this outpatient because we have outpatient centers open at the time, because no regular patients were going there. So in some centers we can get this done. And, they were using you don't have to completely isolate this patient. So they'll go there with a protective. I told them to wear a mask if you're going for an X-ray. When you go to the lab, I told patients to wear a N95 mask at that time, when you have somebody, you don't want to keep the infection to somebody drawing blood. But, so they go to the lab, and there is plenty of labs at that time, available. With a little bit difficulty, but I have some connections on something, some labs were doing it. So we were able to do, like, the CRP, D-dimer, and everything in this patient. So that's very crucial. In these patients who are not responding to hydroxychloroquine, the CRPs are so high. I wanted so that the 140, it doubles like 200. I've never seen such a high CRPs. And D-dimer is, not that big problem, because a lot of people were talking about D-dimer and coagulation. I did CT angio on some of the patients. I never seen a major PE or big thromboembolic disease so far. So majority was the CRP, the inflammatory part. This is so much inflammation going on in the vascular system. So if you hit with the steroid, it's a steroid responsive. The next step is to hit the steroid. So you have to start with a long course of steroids. Not like some people just get 2 days steroid and just stop it rebounds, definitely. So something you have to design, like, 30, you need only low dose, because most of the X-rays were still negative. I did X-ray. In 9th day, 8th day, with the CRP of 150, still the X-ray was negative. X-ray was, most of the X-rays are like mild peripheral infiltrates. When I hospital, I see like bilateral pulmonary infiltrates. So that's totally different than, the very mild pulmonary infiltrates. So you can give like a 30 milligram methylprednisolone tapering dose, like every 4th day. Every day you taper like 2 milligram or something over a 7 to 10, days of, or, even at least a week period. Or in some patients, when you see like very sick, I used a little bit higher dose. First 5 days I used methylprednisolone 50 milligram, then taper it off. So I'm telling you, that particular 2% of the patients were not responding to the high dose chloroquine zinc promax. Again, another 1 to 1.5% patients responded immediately to the steroids. So now we are, almost harassed. And some patients, only 4 or 5 patients, I remember D-dimer was more than 1,000. So I put him on anticoagulation. In Kerala, maybe you can, I think you can Lovenox is okay. But in USA, we have rivaroxaban, apixaban, like, oral anticoagulations. I was using apixaban, like 5 milligram twice a day, those who have D-dimer high. So I put them on apixaban on 9th day, in only patients who have D-dimer high, or those patients are little bit silent. In this patient, hypoxic, I know that some patients are really hypoxic, like not, like if you measure them, it's 80, 82. But when you take deep breath and effort, it goes to 92. So those patients, you can safely manage outpatient. You don't have to send them. Only don't make them panic, or only thing they have to be a little careful at home. You don't have to. If you can supply home oxygen. Some of the patients has home oxygen. We know we were able to arrange, but not everybody. But people were scared to go to the ER at that point. But since it's Malayali community, I was not worried about lawsuit. If I am dealing with the other community, maybe it's a little bit different. But But these people trusted me, so I told them, take deep breath and improve your oxygenation with your breathing. And I told them, I give the option to go to hospital, but they don't want to go. Nobody wants to go. Everybody knows hospital people are like, packing bodies. So I said, okay. So a lot of my patients in this, but that particular category, not responding to dose chloroquine, has hypoxia up to 82, 85. Everybody knows they're happy hypoxia. They don't, because I still believe the inflammation of the blood vessel inside the lungs is yet to be like going into ARDS. It's like a typical pneumonia, but we learned in old school. It's like like interstitial pneumonia. So it's like inflammation of the interstitium along with that, like the vessels. So that point, if you give steroid, is definitely steroid responsive condition. So a lot of patients came back. And in some patients, anticoagulation, definitely. And if you are not able to do like this kind of labs, you can empirically treat them with an anticoagulation and a steroid. If you cannot do the lab, it's not like a completely side effect drug. I don't think that. But don't use steroid in the first week. That's the problem. If you use steroid early, you may complicate. But that's particular day between 7 and 9 the day. If you can hit with steroid, you can hit them. It will go down. And slowly taper. That's very important. Don't taper fast. People just give 1 dose or 2 doses and then taper rebound. That's very bad. Along with the high dose vitamin C, zinc, and everything. So by 9th to 10th day, the hydroxychloroquine regime is finished, and you can see in the MAP plus protocol, the viral load is also really decreased. Even if PCR will be positive, there is don't follow PCR after that. It will be positive for another 6 weeks or something. So definitely the viral loads are coming down. Virus same way like common cold, it increases and taper down. Now the second phase is a cytokine storm, or right now they're saying bradykinin storm. I don't know, but it's that high inflammation. One thing I can guarantee, the CRP I saw that like around more than 150, 200, very high CRPs. So after so about 99.5% of the patients responded to this my regime, and only 8-10 patients out of this 1,200 I have to send to the ER. They were having comorbidities or whatever, but not very comorbidity. I cannot say like it's as any disease. So about 10, maybe 8 to 10 patients went to the ER. So they have to get out of the 10, 12 patients. They just supported them. They got improved, and within 4 days they came back home. So only 4 patients out of this 1,200 some patients. Only 4 patients remained in ICU. for 2 patients in BiPAP and 2 patients got intubated. So out of this 200, the BiPAP patient also went home after two weeks, and only 2 patients got intubated, and they also discharged them after a month. So I'm still sitting at zero mortality. So one steroid and what is this anticoagulation? The last step was tocilizumab. It works. After that particular progression, the people who are progressing on steroid, interleukin-6 blocker, tocilizumab was given. It will definitely reduce another 0.5% of the patients. So it's like a stepwise approach you have to do. If you, this is like an elephant, the people in the different, that's why we are not able to design a common treatment for it. So you have to follow outpatient very regularly until the like 4th day, 6th day, 7th to 9th day, everything, the pathophysiology changes. So so this is my experience. So I'm sitting in like 0 death, and the last step was I told it's tocilizumab, and 2 patients unfortunately got intubated. They have severe pneumonia, and those 2 patients luckily came back. So I'm it's good that they came back. So so that's the treatment regime I used, and so let's discuss about yeah. So treatment part, I'm just stopping there. I will answer the questions. I know most of I think this regime is already in Kerala. Everybody knows about this, but only thing I just, give you how the outpatient, I did that particular regime. I read the Kerala protocol also in between, and it's almost same. So there is nothing different. Only thing is, I was, the self-swabbing kits, and you can manage this patient, the outpatient, and self-isolation protocols. I think don't reinfection. Keep an eye on patient. Don't get reinfection by themselves, and those kind of things are the only things I did a little bit differently. Other regime is hydroxychloroquine, zinc with prednisone and like anticoagulation, and tocilizumab regime is already in Kerala. So but it works. I think you can it's very important to that it's worked for me. It's my observation, but still some of the studies are already proving this thing, and we have yet to see the other ones. So regarding the risk factors, doctor told me to discuss about what are the risk factors I'm seeing. So it's for preventive purposes. There, everybody knows about risk factor now. Youngsters, obesity, obstructive sleep apnea. I notice high triglyceride. People with high triglyceride. Pay attention. High triglyceride has problems with the COVID complications. And diabetes, hypertension. Comparing to hypertension is a more complicated. I see more complication hypertension than diabetes. And diabetes depend upon, what I see was diabetic patients, a lot of diabetic, very bad diabetics, nothing happened. I don't know why. So that's what it's only people just on metformin, or somebody has 78, like 55, 65. They have more severe disease than somebody has 70, even 10, 12, and full-blown therapy, like, like metformin, Janimet, insulin. I have a lot of patients, they were surprised even when I check antibodies coming back positive. Some of these diabetic medications are definitely protecting them. Like I don't know which one they have to do a research, like some of the metformin or Janimet, or even in USA we use SGLT2 receptor blockers. Like Canafalot, glufosinine, Jardiance, Invokana kind of drugs, sitagliptin, GLP-1 agonist. Like Simag, that kind of once a week injections. These cardioprotective, the endocrinologists in the panel can probably know those things. All those medications definitely protecting. Statins, hyperlipidemia, statins and fenofibrate, I see like a very good results. If somebody who is on, this is the time, until the vaccine comes, if somebody has high cholesterol, put them on statin. If somebody has high triglyceride, put them on fenofibrate. And, if the diabetes, just follow the same protocol, what is, any association following. Use more cardioprotective drugs like SGLT2 receptor blocker, GLP-1 agonist, and long-acting insulin as an umbrella always helps. It's all proven. If somebody uses, people are afraid of insulin. If somebody has an umbrella of long-acting insulin, they are also protected. You understand? I know, I saw that. And obesity, definitely address the obesity. And symptoms with sleep studies and OSA, people on, CPAP machines, less severity I noticed. And cholesterol I already discussed, diabetes discussed, then coronary artery disease. This is the time, I usually tell them to take double protection. It's okay. Some people are already on aspirin. I told them to take, another Brilinda or Plavix along with the, until the vaccine comes, aspirin plus Plavix, and other regimes like, all the, guideline-directed coronary artery disease management, congestive heart failure. Same thing, all the guideline-directed, optimized medication. Those people, most of them have died. You can see that they are not optimized from medications, particularly in New York City, because we saw that the African American community or Hispanic community, low socioeconomic, because of the insurance issues in the United States. That's why there are so much of like fight or violence going on in USA now, because of the it's a different system here. So the medical optimization, people who are medically optimized has less severity, definitely, comparing to those who are intermittently taking drugs, because they have insurance issues. They don't take medications regularly. And okay, so regarding the risk factor, that's yeah. So I just want to conclude with the post-COVID complications I see. What I noticed, but if you follow this regime, none of my patients has post-COVID complications. I'm not, it's only mild symptoms. Some people have chronic fatigue, back pain, and very mild. I have 2 patients worsen diabetes, A1C jumped, diabetic worsening, and those kind of hypertension getting worse. In hypertension, I noticed one thing: calcium channel blocker and ARBs are superior. Definitely, I can tell you, the amlodipine or diltiazem and ARBs like losartan or valsartan kind of drugs protects. Because unopposed angiotensin action is one of the reasons, because all the inflammation is happening. So if if those people are on this calcium channel blocker with amlodipine combination, they are well protected. Some of them on diltiazem, I saw that they, obese people, nothing happened because somehow they were taking diltiazem for blood pressure. And comparing to those, so calcium channel blocker and the losartan, I forgot to mention, in hypertension is very important. I'm using it a lot now because it helps. And yeah. Then post-COVID, I get patients some cardiac workup like echoes and make sure. But I be honest with you, so far I haven't seen anybody has stroke or heart attack from COVID in my 1,300 patients. I'm following them, like every 3 months antibody. I know there's controversy coming about antibody. I'm still seeing antibody on these patients until most of them, they're. I follow them every 3 months. When their routine lab comes, I just for my curiosity. Majority, 99% of them are still antibody I'm seeing, but I don't know whether it's neutralizing or it's because I haven't seen a reinfection also in any of my patients so far. So because they are all recovered their antibody and some mild fatigue or compliance, which is from the anxiety. But 99% of the patients are completely fine and they're okay. Yeah. So with this, if anybody has any questions or any, I can answer, because this is, I'm sorry I didn't have slides to, put in the system so people can remember. But this is overall my experience, and if anybody has any questions, I can answer, from my small experience. I'm just telling my experience. I know there are some controversies in this treatment protocol, I know medically, but this is what I did and I had success. So that's why he invited me, and I am able to be in front of all the professors here, and if you have any questions, from my experience, I can give some. Yeah, thank you.
Are you in a hurry? I have a question, sir.
Yeah, no, I'm not in a hurry, so you can.
Then we will keep the questions last.
Okay, no problem. Thank you.
Now I invite, thank you, Dr. Sabu, for your excellent talk and your experiences which you shared with us. Now I invite Dr. Jacob K. Jacob, our next faculty, for his address. Dr. Jacob K. Jacob?
Yes, sir. 1 minute.
Okay. Take off.
Yeah. Good evening to you all. Respected Mohanan sir, Vice Chancellor KUHS, Dr. Gopikumar, State President IMA, and Dr. S. Syamsunder, Moderator, Dr. Joy, Manjula, President IMA, and all other dignitaries and delegates, especially Dr. Sabu, who has shared his experience. I have gone through MASS protocol. It's a good protocol. And I'm sure you have covered almost everything in primary healthcare. Of course, there may be differences in what you practice and what is there in, according to your guidelines in Kerala or India also. And we have to follow our own our guidelines as given. So I just rush through this presentation because most of the things have been covered, and our time is also slightly advanced. So can you hear me?
Yes.
Yeah. My special thanks to Dr. Joy Manjula and Dr. Fatauddin, our Vice Principal and Nodal Officer. He is also the HOD Department of Pulmonary Medicine. And thank you for this opportunity. This is the slogan we are hearing often, and it is true. Now, today, the confirmed cases over the world is 30 million, with deaths almost 9.25 lakhs. In India, 5.6 million, and deaths 79,000. In Kerala, almost it has crossed 1 lakh, and the declared deaths is 400. So, what is really crucial, and it is already said, what I fully agree with what Dr. Sabu said, and the crucial, it is a time. So, we are entering a new normal now. So I think most of the other diseases are also coming down, especially MDR, TB, and other diseases because of the masking and a proper wear of the mask and sanitization, social distancing. But the fallacy is that, as we see in this picture, everybody is still together. Especially if you look at our house agents, our nurses, and most of the today also just my neighbor telephoned me up. There was a marriage. And everyone went there, and now somebody is not feeling smell, somebody is having fever, like that. So, though we see this slogan, many times it is not practiced in the hospital, outside the hospital. So, that has to be addressed. And some basics, again, it is covered, but I want to say the viral loads are highest during the first week following the symptom onset. So, after the symptom, maybe around 4 to 6 days, that is incubation period, the average incubation period is around 5 days, and the first week the viral loads are usually high, and these are the common symptoms. I am not going into that. And see, we have to prevent, as Dr. Sabu said, we should not go into critical COVID stage where the mortality is very high. I will show you some X-rays later time. So high mortality in critical COVID stage. So we have to somehow prevent them from going to that. So we should have a little knowledge about natural history, pathophysiology, pharmacotherapy, morbidity, and mortality. All these are very familiar to us. So I'm just rushing through that. We have different stages: stage 1, stage 2, stage 3. And stage 1 is the early infection. And the antiviral response is also maximum there. I've gone through the different guidelines of All India Institute of Medical Science, then Kerala guideline, and CMC guideline. Most of the guidelines are the same. No much of difference. So antivirals, if you use, the use should be early enough. That is one of the key messages which I want to say. That is why I said what is crucial. It is not the critical care which is crucial, but not going into the critical care phase. That is crucial. So this is another line diagram, almost the same thing, and it's also showing the effect of antivirals. You see, the mortality as I described, it is very high. And one study recently I read, it is saying 100% mortality. It may be different in different centers, but mostly mortality is very high. So we should not allow patients to go to ARDS phase. Now this is a simple line diagram. So you get the infection on the 0 day, then incubation will around 5 days, symptom onset on the 5th day. The day 3, this is a golden hour. Day 3 to day 6. This is a golden threshold, golden time, golden days where we need to treat. So wherever they are say a symptom or A0 or advanced stages, before they go into advanced stages, this is very important. Maximum up to day 9. So this is also almost similar everywhere. So we start treatment in the golden days itself. That is a most important thing. Why I am saying this again and again, I will tell you later. So this is acute and mild phase. So you can see the graph also. The viral load also is maximum, as I said, around 6-7 days. And mortality. See, if the patients go into ARDS, mortality increases from 8th day onwards. And some studies say maximum 8 to 12 days, but depending upon the treatment, it may be slightly delayed. We have mortality even, say, patient being treated for one month and then then die. So that is also there. So what is really important is early recognition of symptoms, early reporting for tests, early initiation of treatment, early detection of progression or worsening. Even we have reports of deaths occurring in FLTC or at home, finding people dead. So that also has to be addressed. The literature says early recognition of severe infection may allow early intervention with supportive measures and therapeutic improve, the outcomes improve. So if a negative person, we should do prevention by SMS, vaccine or whatever. Vaccine is not available. In a positive patient, early initiation, prevention of progression, early detection of worsening. Okay, the host factors which are important are already covered, older age and other comorbidities. And an LLR, I will come to that NLR ratio. That is very, very important. Even in an FLTC, we can do this NLR. Even at home also, we can do that. High risk patients, I'm not going to that. We know who are all high risk. See, this NLR ratio, that is, it is, there are a lot of reports and a lot of literature coming up. That is our experience too. Neutrophil lymphocyte ratio. After all, CBC is very expensive, very inexpensive, and we can do that very cheap. An absolute lymphocyte count. It's the reliable prognostic marker. And whomever we see a high NLR and a low lymphocyte count, very bad prognosis. Or we have to be very careful. It is simple, fast, and you can do it. So a lot of literature coming up. So this we have to remember in our mind. NLR ratio is a very useful tool. And it will also help us to do risk stratification. And there are several atypical presentations. So COVID is now previously syphilis or HIV were king of the disease, or even diabetes. But now I think COVID, because lot of atypical presentations. So any atypical presentations, we hear a lot of news, people dying and taken to the hospital and finding COVID positive. So any atypical presentation or any extrapulmonary manifestation, we have to be careful. And this virus, as we know, is knowing this is very important for our management. It's a multi-pronged virus. It has a camouflage enzyme. It has an RNA proofreader splitter. It binds to ACE2 inhibitors. It upregulates ACE2 inhibitors. It dysregulates the renin-angiotensin system. It triggers of the host immune system. It has affinity to iron and heme, and that is why it is causing a multi-organ dysfunction. And the deaths are so much because of this multi-pronged approach. And see, basically, as already described, it is finally causing, the end thing is it causes hypercoagulability, endotheliopathy, and macro and micro thrombosis due to various mechanisms. Now we can remember a few H: hypercoagulability, hyperimmune response, hypovolemia, hypoxia, and then there is a vicious circle. So patients will deteriorate. So what is really crucial? What is really crucial is not going into critical care. So negative patients you prevent from going to mild to moderate, and mild to moderate prevent them from going to severe or critical, because deaths are high. So we have to break the chain. We have to protect ourselves also. That is also described already. And as our Dr. K. Mohanan sir, respected Vice Chancellor, Honorable Vice Chancellor said, teaching this to people are important, because people are not wearing masks properly. Even doctors are not taking care properly, not detecting early. All these we are going through every day. Even now, people are crowding, and we have to teach them. Teach the doctors, teach the nurses, teach the general population, and keep testing, tracking, proper triaging, and treating them, and also using telemedicine. All the keys we can remember. Okay. So what is most important? Once again, I want to repeat. I will repeat again. Early recognition, early reporting for testing, early initiation, and early detection. So we have as the virus is multi-pronged, we also have a multi-pronged approach. Anticoagulation, anti-inflammatory management, antivirals, antibiotics when needed, oxygenation, and supportive treatment. This is the crux of the COVID therapy. All over the world, it is like that. So most important is time. How often, even though we have all this, how fast we use, how fast we detect, and how fast and appropriately we do it. That is the most important thing. Because recently one patient came to us, he was sitting at home with 12 days breathlessness. and he has very severe ARDS. I will show the X-ray. So very severe ARDS. Why? He was sitting at home. He was a very important person, but sitting at home. So that is why the initiation of treatment, even if they reach home or even if they are in FLTC, they have to be seen again and again. So most important is time. And I don't know, this is a very comprehensive, and I have put everything together. It is basically from the Kerala guideline. We have risk stratification to A, B, C, and according to the clinical severity, that is also incorporated into that. So we have basically mild, moderate, severe, and critical. Mild A symptom or no symptom is A0. This is A symptom, B and C mild symptom. So I'm not going into the details, we don't have time. Then the moderate symptom C. See, moderate and then severe symptom, finally critical. Now the most important fact, crucial fact is that they may slip from one to another in hours time. So it is our responsibility to monitor properly and have stringent criteria for monitoring. That is the most important thing. So that we can take as a take-home message, and they have to be properly. Even if they are positive, they have to, or sometimes they may be suspects with all the symptoms but a negative PCR. So then we have to, in the hospitals, we have to accordingly segregate them into positive room, suspect room, negative room, then sending some A0 and A to FLTC like that. See, that is a thing which we are doing in COVID hospitals and other places all over Kerala and in other places. So any positive person, suppose they are going into an FLTC, and see, home quarantine is not widely practiced now. It's only coming in because according to government protocols only we can do that. So any positive person, wherever he is, he has to be evaluated frequently according to where he is, according to his severity. And vitals, respiratory rate, pulse rate, temperature, SpO2 have to be measured. And even if in the hospital, daily reclassification has to be done. Okay, and there are basic investigations and advanced investigations we do. We may go in for an early CT in the hospital because sometimes X-ray will be absolutely normal, but CT will show many findings. Now, when we come to the treatment, okay, when we come to the treatment, almost everything is already described. Just putting in the streamlining again, according to our guideline, see, in the mild A symptom, again, I will come to that. Then, see, what do we do? We watch the symptoms again. See, watching and again observing is very, very important. Watch the symptoms. You can do a 6 minutes walk test or 40 minutes step once in a day or twice in a day to see if there is a fall in SpO2. Then watch the vitals. Then PCM according to the weight, paracetamol. Then, as I said, zinc, vitamin C, thiamine, vitamin D, all these have been tried in different places, in different literatures. So then adequate hydration, nutritious food, and casual walking also, because if they are always lying down, they may develop a DVT and pulmonary embolism. So that is also very important. But they have to be reassessed frequently, and whether they are going into B or B+. So there are a few tips in FLTC or wherever in a part of primary healthcare. Avoid, SMS is very important. That means wearing masks, sanitization, social distancing. Avoid NSAIDs. Avoid injections. You can just try paracetamol. Nebulization is also avoided. If they are on steroids, continue that. If they are on ARB, CCB and all, we can continue that. Management of comorbidities again is very important. Gentle walking and azithromycin, of course, because of its immunomodulatory effect. And there are a lot of indigenous medicines which we are not very sure. It may cause damage also. I have no comment on that because we are not using it. And even in A0A, we can do a simple CBC and see if the NLR is worsening. Watch for any symptom, reclassify, monitor. Early report to the hospital if they are progressing. As doctor said, telemedicine, we can use that, or in FLTC we can do that. See, coronary events, I will come to that very fast. So this is category B and mild C. That also will go into mild according to the Kerala guideline. A, B and C mild will go into the mild clinical severity. So here we have to also see whether the patients are high risk, and we have a lot of drugs also coming in with the various mechanisms, and we have to do certain pre-medication tests, and post-medication tests are also needed. I'm not going into the details. Finally, we come to category B, B+. See, all that we have done in A or A0, we have to go do in B and B plus. Plus, what we can do? We can do again, monitor them, manage the comorbidities well, watch them and do their vitals and see their oxygenation, everything. And according to our protocol, B onwards and B plus, mostly we are keeping in the hospital, especially B plus means B with symptoms with comorbidities, they are B plus. And of course, C onwards, we don't send them to any FLTC or home. We are keeping them in the COVID hospitals. So for them, we are giving SCQS, that is also there in AIMS protocol. SCQS, we are giving them azithromycin, and if they are negative, till they are positive, we can give oseltamivir. After that, we don't give oseltamivir. Once the test is positive, no need for oseltamivir. And low molecular weight heparin, if there is a high risk patient, we give DVT prophylaxis, OD, and these are the things which we do in B and B plus category. Again, we reassess them. We reassess them every time. That is the most important. Try and reclassify them, whether they are going into C. Now, this is very important. And so here, what it says, in C, it may be more than 24, but they may easily slip into C. So there we have to intervene. What are we doing? We have to do awake proning. Awake proning. The B also we can do that proning, no problem, because proning will help in good perfusion in the lungs, and also it will help in oxygenation. So dexapron we have been doing in our hospital. That's a name coined by our nodal officer, Dr. Fatawuddin. Dexapron means from the world study Dexona and awake proning. That is for C mild category. And then no molecular weight heparin. So this is a crux of the treatment. Oral anticoagulation, low dose steroid, and awake proning. Then if we have antivirals, we can add favipiravir, and we can, if that is not available, we can try azithromycin carefully along with the SCQS, or if still that is not available, we can use lopinavir ritonavir. So we have good experience with lopinavir ritonavir. I don't want to go into the details, but even in the early days when only lopinavir ritonavir was available, we were doing that, we were using that, and we got good results. And awake proning, this is the awake proning. Then moderate. Then the moderate category. So see, according to our category, moderate C means patient is having dyspnea, hypoxia, and we look for the red flag signs. Here, oxygenation is falling, respiratory rate is also increasing, pulse is increasing. If you do a CT, it will be more than 50%. Now we have to be very careful with these patients, because again they may slip to severe or critical. And for them, what is the additional thing we are doing? We continue all that we are doing A and B, we are continuing. Plus, we closely monitor them, add Dexona injection, then low molecular weight heparin, and mostly if they are in ICU, for some reason, we give methylprednisolone. And we give them oxygen. Here we have oxygen. And sometimes ICU there may not be, but we manage them in a high density, high dependency COVID ward. There also we give oxygen. Non-rebreathing mask is enough. So oxygenation, sequential proning, low dose steroid, low molecular weight heparin. And according to our protocol, if we have remdesivir, we can give remdesivir there. And COVID convalescent plasma, there are a lot of studies for and against. We are doing COVID convalescent plasma also there. And if there is a need, we can add injectable antibiotics. And definitely we should have reassurance. We have a team of psychiatrists looking into their mental status, and we take a consent, all that is needed. Again, we monitor them. That is very important. Then whether they are slipping into severe category C. Okay. Here we have to remember, oxygen without anticoagulation has no significance. Oxygen, if you give anticoagulation, is very, very important. And if they are under home care, as mentioned, we can give oral anticoagulation. Anyway, we have to monitor. What do we monitor? We monitor their whether the work of breathing is increasing, their hemodynamics, their oxygen requirement, and some of these tests, especially NLR, CRP, as already described, we monitor. That is what we do in a COVID center, and see whether they are going into severe. I am not going to describe about severe, critical. That is all. So, what is most important? In the primary health setting, and not only that, in the hospital regarding treatment of A and B plus and C mild. before going into moderate or severe. We have to prevent. How this prevention, early recognition of deterioration, early treatment, timely treatment, that is very important. So prevent negative to mild to moderate and prevent severe illnesses. The mortality of ARDS is very high, as I said. Some studies say 100% mortality, but in general around at least 50% mortality. So, and there are a lot of complications of critical illness. We know that. I'm not going into details. So all this have to be prevented. This is one short form which I have commented. See, all the organs, we find injury to multi-organ injury. Lungs are injured, heart is injured, vessels are injured, the renal system is injured, liver injured, even pancreas is injured. So COVID multi-organ dysfunction, it is a comedy. So remember, comedy is COVID multi-organ dysfunction syndrome. COVID multi-organ dysfunction syndrome. So every organ is involved. And see, we have just now one of my friends said one person was admitted in the hospital ward. There was no symptom. Just I think around 30 years only, suddenly died. And we have also had similar experiences. Some of them we could save. It is because of acute myocardial infarction because of endothelitis. Patient going into, in spite of oral anticoagulation, they may go in for. That is why one of the important cause of sudden cardiac death. So it's a known fact. People may die of endothelitis and acute myocardial infarction. Very common and known fact. So we have coronary syndrome. Our nodal officer has coined this term, acute coronary syndrome. Even in A0 or A and in young without comorbidities, acute coronary syndrome can occur. Coronary syndrome. So acute death is possible. It is. We are facing it every day. Even last day, 2-3 patients suddenly developed all this. We could save them. I will show a few X-rays and stop. This is one of the X-rays of one of the first patients we had. He had X-ray features and we did a CT scan. It was showing bilateral, but we had only hydroxychloroquine, azithromycin, and even lopinavir, ritonavir nobody was using. So we got immediate permission from the state medical board, and we gave lopinavir, ritonavir, and his QT got prolonged due to azithromycin SCQ combination. But then finally we had to stop that. But with lopinavir, ritonavir, and oxygenation and steroid and low molecular weight heparin, full dose low molecular weight heparin, therapeutic heparin, and low dose steroid, he improved well, and we could send him home. And you can see that X-ray has cleared after a few days. So this is another patient. See, recently he was at home and he did not seek treatment, and see bilateral full-fledged shadows. And he's an elderly person with not much of comorbidities, but I think he had a tough time of ARDS. Now this is another person, obese, 110 kgs. You can see this bilateral shadows. We gave him even all the treatment, that is therapeutic low molecular weight heparin, low dose steroid. He was not responding. Then tocilizumab was out of stock throughout Kerala, and then we gave him remdesivir with 3 days remdesivir. I don't say that it is only due to remdesivir, but anyway we gave. We are not sure whether it is due to remdesivir. Maybe the therapeutic low molecular weight heparin and steroid and all the other supportive treatment. You can see his X-ray. After the 3rd day, X-ray started improving and his oxygenation started improving. And this is another person, a 100 kg a lady. You can see this lady actually went to one of our government hospitals, and they did not see she did not have any respiratory symptom. She had other symptoms, and they thought other cause of fever, and finally they simply took an X-ray and found that it's an ARDS. And then the testing was done. So this is why I said even now crowding is occurring. So teaching, being aware that even an asymptomatic person can be a spreader. Asymptomatic person can be positive. Asymptomatic person can kill us. So the message to doctors, nurses, healthcare workers, and everyone is that we have to be careful. A universal precaution with SMS and not crowding. Thinking that every person can be, even a home clustering is going to come, domestic clustering of a lot of patients occurring in one family, that is also going to come. And this is the reason, happy hypoxia, but inside suddenly patient may deteriorate, and we may not be even able to intubate. This is another person, a lady, 110 kilos. See, we never thought this person will improve, because you can see the second X-ray. See, it is full. There is no lung left, full. But surprisingly, with the standard treatment, She had even, I think, liver injury, kidney injury and all. So many of the drugs we could not use, but with the standard treatment and proning, it was very difficult to prone her also because heavy weight and a big tummy. So, but surprisingly, she improved. And this is one of the very sad X-rays. Again, a delayed presentation. So that is why I said timing is very important. Sitting at home with symptoms. Once the symptoms start, 3 to 6 days, very important. That's a golden period when we have to treat. That is a take-home message. And this person we could not save because immediately he progressed. And that is very, very sad. Okay, even though without much see, he had OSA, as mentioned, OSA and morbid obesity. That is enough for mortality. Obesity and OSA and diabetes, hypertension, CVD. So all these are having high mortality. So it was also a delayed presentation. Sitting at home, somebody said you sit at home, no problem, and came with very bad shape. So with all this armamentarium of treatment, which I said, we are still very much behind. Lot of deaths happening. Even if it is a one death, it is 100% for the family. So we cannot be satisfied. There are a lot of other drugs which are being tried, okay, it is also personal experience and different literatures. Mortality is high in advanced stages. That is what we have to remember. So prevention is very important. Remember the COVID window, the treatment window of 3 to maximum best window. It is not that after that we should not treat. We should treat, but if you intervene early, that can prevent progression. Of course, post-COVID syndrome, we are facing a lot of symptoms. It is already described. And post-COVID follow-up also very important. 3 months, 6 months, even a few years. Because we do not know anything much about this virus. We are only still learning and learning new facts. And even I do not know anything much. I'm just sharing from my experience, though I used a PowerPoint. I know there are a lot of delegates who know much more from your experience and knowledge. So post-COVID follow-up and a networking of follow-up is very important. With our e-health of Kerala government, I think it may be possible because time to time we may have to do a cardiac workup and a respiratory workup, even a psychiatric workup to assess these patients. And this study may have to go for a few years now. Then only we will be able to exactly learn this virus. And the most recent thing which has come up is there are a number of variants, especially in Kerala. So whether how these viruses are going to behave, whether our viruses will be effective, whether their virulence will come down or whether it will go up, all these things are in store for us. We are not very sure. As Sir said, we may have to do a number of researches in the coming months, and then probably we may come across new findings. And prophylaxis, of course, prevention is very important. As I said, a universal precaution of SMS, then hydroxychloroquine on all our protocols. It is for prophylaxis. It is only for healthcare workers, but we have to be careful with that. We have to have evaluation in between. Then boosting up our own immunity through walking and good food, good sleep, good rest, and a teamwork. Teamwork is very important. And of course, vaccine is a few months at least away. So universal precaution and PPE, wearing PPE properly. Proper wearing of PPE is important. SMS and disinfection, proper disinfection of all the articles we use, even door handles and other things. Even the coins which we get from the shop, that is also important. So as much of precautions which we can use, and highly suspicious. Even a small fever, don't ignore. We have to be highly suspicious, and remember that asymptomatic spreaders are more because 85% are asymptomatics or with mild symptoms. So we have to only 15% actually come in A or B or C category. 85% are asymptomatics but positive. So and even now more than 50% we do not know from where they got the infection. So that is also there in Kerala and India. So teaching all this and learning. Testing, tracking, triage, proper triage, treating, and even using telemedicine. So the take-home message is early recognition of symptoms, early reporting, early initiation of treatment, early detection of progression of worsening. Time matters. Time is important. Timely intervention is important. So we will win this global battle against coronavirus, no doubt. Thank you. Sorry for taking this much time. Thank you.
Thank you. Thank you, Dr. Jain.
Thank you, sir.
Screen share off here. Screen share. Okay, thank you. Thank you for your excellent talk. Now the forum is open for discussion. Dr. Indudharan? Oh. There
Yes.
are few
Yes.
questions. Just
Hello.
take care of the chat box. Dr. Indu?
Yes.
Chat box il nokiya questions ഒന്ന് വായിച്ച് പറയൂ ചോദ്യം.
Okay. Actually, I will read a few questions. We may not have enough time to answer all the questions. Dr. Srivalsan had asked a question to Dr. Jacob. Why does hemoptysis occur in severe cases? How do you differentiate between usual ARDS and COVID ARDS? What is the earliest X-ray test of sign of lung involvement? Why is conjunctivitis seen in COVID disease?
One minute, Dr. Indu, 1 minute, excuse me,
Yeah.
sorry for the missing. I invite our moderator, Dr. Syamsunder, for the question answer, and before that, let him express his views on COVID.
Actually, I thought Dr. Syamsunder got disconnected in between. Actually, he can do this. He can go to the chat box and he can moderate.
Now he's there. Now he has come back.
Okay.
Now he's there. Dr. Syam? Hello? Dr. Syam? Can you hear me? Hello? And the block, I know. Dr. Syam?
People have muted themselves. Please ask Dr. Syam to open.
No, he is not muted, but he has put, I think, please. Dr. Syam? Dr.
Yes,
Syam?
yes, can you hear me?
Yeah, we can hear you. Please, support you. You can express this thing and take the chat box also.
Thank you for the speakers. And we have seen that the two extremes of treatment or after China. Can you hear me?
Yes.
Yes, we can hear you. We can hear you.
After China, we are the highest population in the world with a COVID infection. And normally we should have the highest number of people also. And we think in Kerala, we are the best people who is treating COVID till now. And we just want to hear what is happening in the developed world. And we just heard from Dr. Sabu that what is happening in USA and what is the number of treatment protocols there and what we heard from our Kerala. And we have to be proud to say we have got a very comprehensive and very simple protocol to follow for all of us. And we are also following. My hospital is having 300 bed strength, and out of the 250 people are already admitted to category B. We don't take any category C. And we should know, as from Dr. Jacob's presentation, that category B is the highly likely to progress to category C and can have death. So one other thing we see, I am surprised to say the USA that is still going on. And whatever that is, what the state medical board is doing death audit, and I have met a number of death audit team. And we are also scrutinizing each death, what is happening, how people died, and what we missed. And most often, most of the things which can't be explained by the current knowledge, why these people died. And there are so many people with current comorbidities, they miraculously survive. So how these people progress, we are yet to know. So that is a good presentation, and I think a lot of people from Kerala is also from IMA and physicians also heard that presentation. They should have questions to ask. And from my experience, and we have several symptoms, and people are most of the time asymptomatic.
Dr. Shah, please unmute.
Hello. 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 Can you hear
Yes,
me?
we can hear you.
My host has muted me. That is one message come to me. Okay, thank you for all the. I don't take much time. If there are any questions to ask
No,
by others.
wrongly unmuted. Sorry, wrongly muted. Okay, carry on.
So I express my gratitude for giving me an opportunity. I think any others have questions, they can
No,
ask the question.
you check the chat box and read the questions. Dr. Syamsunder.
In my checkbox, there is not questions are there. Only
there are plenty of questions are there.
Meanwhile,
I will invite
Dr. Joy, this is Dr. Fatahuddin.
Okay.
And
thank you.
Thank you so much for arranging such a wonderful CME. Dr. Sabu Varghese and Dr. Jacob. Jacob has actually delivered an excellent talk. My question is to Dr. Sabu regarding his primary care treatment. Of the 1,200 cases that you have seen, how many of them were above 70 years? Where all of them are Asians? And what is the criteria on which you started aspirin and statin? Irrespective of the age you have started, depending on the moderate symptoms only, or you have started with those who are having comorbidities? Over to you, Dr. Sab.
Dr. Sabu, unmute. Please unmute and talk.
So about among the 1,200, maybe about 70 to 80% patients were more than 70, and they have multiple comorbidities. Majority are Asians because my practice is fully based upon Malayali population, and very few probably other So most of them were Malayali population, and I didn't follow like any specific numbers, but whenever patients develops, as Jacob said, one of the main pathology is endotheliitis. So if if your arteries are atherosclerotic, that's why more age, you have more atherosclerosis. When the inflammation comes, you develop MI and die. That's what it is. So it's always treat these patients like non-ST elevation MI. If the patient's progressing from moderate to you get a feeling that this patient is going forward. So you don't have to, I didn't use any parameters. I just loaded them with the aspirin and anticoagulations and moderate dose of Lipitor. And as I said, and I see in my primary care practice, even in patients who are younger, those who have risk factors, still statin is protecting and fenofibrate is protecting. So basically, I used my common sense at that time because most of the time I was treating in March, because we don't admit patients here. We were following, only, once they are very sick, they can go to the hospital. So, basically, it's our, as Dr. Jacob said, from the literature and stuff I found out, endotheliitis. So I felt most of the patients are dying from MIs and vascular, pathology. So what is the best way to treat vascular pathology? Available is aspirin or double protection with aspirin or Plavix and Lovenox, and, or in anticoagulations and fish oil. We have a SIPA here. I don't know, it's available there. There is a new fish oil, which is very protective endothelium, it reduces inflammation. And, so I just added to those patients with progressing to moderate. And, I don't know whether it's worked because the research has to come. Because
how long you have advised them to continue this?
Usually I didn't stop yet. Most of the patients are still on until they cannot tolerate. Some patients develop after 3 months statin, probably intolerance. Then usually I told them to stop, Usually, you have to taper it down because initially 40 milligram in elderly patient, you can go around to 20 milligram of Lipitor. And it's your common sense right now because there is no particular guidelines. So, it's like you can follow the American, whatever Heart Association guideline in this, or, even Indian cardiology, whatever the cardiology recommending, you can follow. It's basically, there is a cardiovascular problem, which is major, most of the patients are dying from that. That's, same way Dr. Jacob said, I felt also same way in hospital. There is sudden death, very common. What is sudden death is always heart, this very simple, so it's like a, endotheliitis is the major pathologies with the, hypercoagulability and, that's why the CRP is 200. It's from 0 to 200. How can I have 1 week, to have a CRP that high level? So, so you have to, whatever measures to reduce, these are the measures. I think you can follow the CRP also, or what he said, CRP is the one which I used, for suppressing anticoagulation, inflammation and everything, and basic protective measures like aspirin, statins and fish oils, and even losartan and amlodipine. That's another big, thing. I always put them on if the non-renal failure or something, because it reduces inflammation. You know that losartan after MI, it reduces mortality. So same way you can treat these patients with some kind of ARBs. I didn't use much AC inhibitors because there is something, but most of the time I use ARB because and other thing is amlodipine or calcineurin is a vasodilator effect. And even in alpha blocker like prazosin, cataprazosin has some positive impact. I'm hearing that. So sometimes, that also helps basically you have to dilate that vessel. It's more, it's very inflammatory condition of the blood vessels. And yeah, that's my experience.
So basically, I have asked this question because, as you have said, we are having a couple of young deaths occurring while on home quarantine. Yes. Or in the CFTLC. So we don't have a guideline from the state or something. So in our close groups where we interact, many questions has been asked to me whether we can use aspirin. So my suggestion was you have to in fact start at least 150 milligram, because it's yes. standalone antiplatelet. So it's a standalone stuff. So at least 150 milligram aspirin you have to use, and you have to continue it until 6 weeks. Yeah. After the RT-PCR becomes negative, wherein I suppose the hypercoagulable state comes down. So this is at least for our doctors, at least for our doctor community. This question has come from most of them are doctors. They were asking, can I take aspirin because I'm above 50? I said, yes, you take it. Yes. There's absolutely no problem. But aspirin I don't have a recommendation. The problem is, we know that there is no aspirin recommendation for primary prevention of coronary artery disease. That paper has gone off because of the increased risk of bleeding. So the increased risk of bleeding. So at least for this corona time, we should be able to do a primary prophylaxis to prevent a coronary event. Thank you so much, Dr. Sabu. Thank you so much. Yeah, thank you. That I take off. Yeah.
Dr. Syamsunder.
The chat box.
Chat box questions in there.
There is a question here about early plasma therapy. What is your take on that in US?
The plasma
therapy, early plasma therapy. Recently, some controversial reports have come that is also not very effective. How is it practiced in US?
In my practice, it was not that effective, but we didn't use early at that time. Right now, we have to use it because we don't have enough patients now. But in the ICU settings, we didn't get much good results.
Dr. Jacob, any comment?
Yeah.
Unmute and talk, Dr. Jacob. Unmute and talk.
Yes, sir. Thank you. So we have been recently doing plasma therapy, but this problem with plasma is, one thing is, all literature is not supporting it. Still, according to our guideline, the Kerala government has given us guidelines, so we are free to use now. But we are using plasma along with all other treatment. We have no different arms, so we cannot say whether it is effective or not. But then at least it will give some protein. That is all what we can say. But but it is a very important aspect of our guideline now. So we have to do it. We have to do some studies, but then proper control study, a randomized control RCT has to be done for exact this thing. But in a pandemic situation, it may be difficult.
Somebody has asked a question here. Depending on the availability, which is better, favipiravir or ramsedivir?
Yeah.
Dr. Joy, please see to the chat box.
Okay.
Please read the chat box questions.
Okay.
I'm reading from chat box. I'm Dr. Indu. I'm reading from the chat box. Favipiravir versus ramsedivir. How to select?
You missed the initial question, sir.
In US, we are selecting remdesivir over favipiravir right now. That's the protocol.
Yeah, probably availability would be the answer, probably.
Yeah. Remdesivir is the one we are using, right now. That's the protocol in my hospital. But, we
And
haven't
Dr.
seen a patient.
Prashant,
We haven't seen a patient in a month. So it's very difficult to say.
Dr. Induran, please scroll upwards. You will to see more questions.
Dr. Prashant has asked a question here. How to use NLR, D-dimer and CRP in decision making? I think it has been covered very well by Dr. Jacob, but still any further comments?
The NLR is a very useful, simple method. And if the NLR is above 3.5, we have found that all patients with above 3.5, they are going into C or critical, severe or critical. And we have to be, even we can do it again and again. There are patients who have NLR maybe 10 to 15 like that. That means absolute lymphocyte count is coming down. There is a pathophysiology mechanism, but I don't want to describe it now. So NLR is very useful. I feel NLR should be done even in the mild cases, so that we will be able to segregate these patients and we will be able to watch these patients. So from our experience and from the literature, it is clear that lymphocytopenia is a grave prognostic marker. So it is very, especially if it is going about 3.5, then we have to be very careful, because that means it is moderate or severe.
Yes, doctor, you had very well explained it in your talk also. Now here is a question from Dr. Srivalsan. Why does hemoptysis occur in severe cases? Any comment on hemoptysis?
That is to Dr. Jacob.
Yeah. So we have seen the number of patients coming with hemoptysis is very, very less. Only very few patients come with hemoptysis. The reason is, there are multiple reasons. One, as part of ARDS it comes, but then it is also this is small capillaries are actually affected. There is a vasculitis. It's basically vasculitis. It's a part of immune mechanism, and the permeability of the capillary is also increasing. That is a reason why there is recently one of the recent theory is that bradykinin is there. So bradykinin is causing very small vessel dilatation and injury to the vessel. So naturally we expect hemoptysis, but hemoptysis as such is one of the red flag signs also. That is also signifying the presence of ARDS and infiltrations. But only few patients come with it. Very few patients come with hemoptysis.
Dr. Jacob, what about
anybody wanting to ask more question?
How will you differentiate between the ARDS, common ARDS with COVID ARDS?
Supposed to be happy hypoxia. So how do you suggest walking, 6 minutes walking and test about hypoxia?
Yeah. So even if the SpO2 is normal, if the NLR is high, if the CRP is high, if the inflammatory markers like LDH is high, or any other inflammatory marker, or if the symptoms are high, or if they are having comorbidities, that is why every time to time we are reassessing them. One of the best methods, even if the SpO2 is normal, that is a patient may not have even any symptom also. Best thing to do is make them walk at least 40 steps. That is a test called 40 steps. And we have found, even when we are trying to transfer the patients back from the ICU to the ward, we do that test, and we have found that it is coming down. So we do not transfer. So 6 minutes, we have to make sure that patient is stable. We have to be with them. They may collapse. All those things are there. But 40 steps, even 40 steps test is enough. So then if they show a fall, that means they are likely to deteriorate. So that's a very important thing. And we have to address that situation.
How will you differentiate between ARDS of common people with and COVID ARDS?
Once they come with fever, they have become category B and they got admitted. And the next day that fever is over. So after 3-4 days, we have to transfer them back home. So what I suggest is, can the 40 steps can be taken off the indication for discharging from them from the hospital? For Dr. Jacob, sir.
Hello.
1 minute. Can I interrupt you in between? Just excuse me. Dr. Sabu wants to leave the meeting. He has got some patients waiting for him. So I think no questions to Dr. Sabu, I think.
Yes, I have got questions. I have got.
Just ask him.
What is the role of melatonin in the treatment, Dr. Sabu?
Melatonin, it's a part of the math plus protocol, what he, Dr. Jacob was also mentioning. It helps, it has some, antiviral activity according to some studies. I'm not an expert on that, but it's mentioned in the math plus protocol, those who cannot sleep because probably they're sitting in a closed room and not coming out for 14 days. They have, what is it, developing maybe a circadian rhythm problem. In order to overact, maybe balance that, probably melatonin 3 milligram, in the night will help, to sleep and, that's reduce the stress. That's the only thing. It's mentioned in the math plus protocol. If you have any doubt, you can go and read in the math plus protocol, as
math plus,
Jacob mentioned. Yeah, it's mentioned
how
there.
Does, how does famotidine act in the treatment?
Famotidine helps most of the patients taking on famotidine outpatient. Most of them have mild disease. I noticed that it has some antiviral activity. Probably, I don't know. We have to do research on that. I am, so I'm not an expert, but I noticed that. That's my observation in outpatient settings. People taking famotidine has less severity, definitely.
One more question. Well, you told that the slow tapering of steroids is better. Why? Slow tapering.
Because I have seen patients, a couple of patients rebounded, because when I initially I was using maybe, like in some patients because of, they have uncontrolled diabetes, I was tapering off very fast. I found rebound in some 2 or 3 patients. So I was using little bit slow taper, over a 7 days or 8 day period, and which helped me starting, slowly. It's mentioned in the old book, steroids should be tapered slowly. So it's not a new thing, but sometimes in this pandemic, old medicine is better. So all these, so that's why I taper over a time slowly. Yeah, I understand. That's why, so it's, maybe, sometimes I have to escalate also, from the slow dose steroids, some patients are not improving. I bump up the dose and then prednisone 50 days, then another medrol slow taper. It's like, it's each patient different,
Dr. Sabu, this recovery trial in COVID has recommended only 10 days dexamethasone or any other steroid.
Yes.
So if you give it for less than 14 days, there is no need to taper it. You mean to say that in COVID, you keep on giving steroids for more than 2 weeks?
No, I didn't give more than 2 weeks. I said it's 7 to 10 days.
So in 10 days, you really need to taper.
I tapered it. That's what I did, because most of the prescription in outpatient setting here comes like tapering dose. It's median prednisolone tapering dose. That's what is in outpatient setting, the most of the American prescription, because we have a medrol dose pack, which is the one I used. We start with like a 32 milligram something and a 28, 24. That's what I used, and it worked for me. So I didn't I haven't done a study or something, but that's what I used.
What I said was the standard teaching, even though postgraduate, is that there is no HPA axis suppression if you use it for less than 14 days. Since you have the tapering pack, that may be due to avoid the misuse by the patients. That may be the reason why American packing has come like that, tapering dose of steroids. So
no, it's not. It's been there since long time. We used to have that kind of tapering package available for outpatient bronchitis or reactive, like some kind of reactive cough, reactive airway disease after viral. I was using it at outpatient. So it's I was giving in patients who have developing moderate to severe like symptoms. And I only very few patients I used, probably maybe I never used everybody. Most of the patients, as I said, 99% of the patients were responding to hydroxychloroquine, Citromax, and zinc regime. Because I used only maybe 7, 8, 10 or 10, 12 patients. I have to use this steroid. In fact, because in March, because literature was not great, but only people who didn't respond to hydroxychloroquine, that was the map. At that time, the DEXA study was not there. I was using the medrol dose pack, and I saw patients responding. Those out of 10 patients, 12 patients, about 9, 10 patients immediately next day they felt better. And only 2 or 3 patients, as I mentioned, progressed to That's my experience. And then my experience majority in March, because there was nothing available at the time. So maybe you're right. I agree, because the research may say we can DEXA protocol has to be followed, but I think outpatient, still I don't think there is. I don't know whether there is a, US we have an outpatient therapy still recommending any type of steroid therapy now still. So I'm just using to my experience. That's what is, so, maybe something has to have to come. I think, in Kerala, I know people are getting admitted and, like moderate symptom. Here we are still, if you go to the ER, they will discharge you. So still they're not admitting any patients here. Only if you develop severe disease, they will keep you in the hospital. Otherwise, they will send you back because, that's what is the CDC guidelines. So I think, I have to use my common sense. That's the only thing I was using at the time. Yeah.
Okay.
Thank you very much for a very informative session. I have one question to both the speakers. What do you comment? What is your comment on reinfection of COVID?
I haven't seen any reinfection so far, as I mentioned, and I was following the antibody in patients. Right now, 6 months, majority of them still have antibodies, and I haven't seen a single reinfection so far, but PCR is coming positive in between because I have a lot of NAIDS patients which are getting surveillance in the hospitals, but they have no symptoms. I believe that's dead virus or whatever, I don't think they're active, you can culture the virus, so it's not active disease. They're developing is, one test, 1 week they're positive, next 2 weeks negative, another one test positive, they come, so it's like, the nasal PCR sometimes comes back positive, but I don't think that's a reliable reinfection, so they have no symptoms. So it's persistent, some kind of, RNA in the nose or, something. Maybe Dr. Jacob can comment. As I said, yeah. I haven't seen anybody. Absolutely no reinfection.
Actually, we are at this stage, we are not able to really say whether it is reinfection or less, but 2 instances I remember. One person was treated for 2 weeks with all kinds of antivirals in Gulf, and 2 weeks and 2 tests also were declared negative. But then on the way in the flight, on the way to Kochi, he developed symptoms again. And then he came here, we found that it was positive, and he was also symptomatic, very much symptomatic. But he was declared negative there. He was given antivirals also. And then we had to treat him for 2 weeks. Another patient, we ourselves treated for 2 weeks. We were about to discharge. And the patient immediately developed that day, again developed symptoms. So whether it was a relapse or reinfection and all, we are yet to see. But one thing is sure, there are mutations coming up now. So the mutant viruses like dengue definitely will can cause a reinfection. So we are yet to see that in the coming months. We will know that.
But Dr. Jacob, there was one case reported in Hong Kong and recently one case in Bangalore, reinfection. Is it not?
Yeah, it is there. It was there in the reports. Yes, sir.
So I have a question regarding a sudden death. You have explained it is due to myocardial infarction. Whether any chance that it can be due to myocarditis leading to some fibrillation? Any chance in asymptomatic
yes, sir, acute fulminant myocarditis can occur at any time, leading to arrhythmias because the endothelitis is already there. So it can cause a sudden acute myocarditis and fulminant myocarditis and arrhythmia and all. But similarly, acute coronary syndrome chance is more. Recently, we had a patient, he was okay, he had no symptoms, no chest symptom at all, only 5 days. He was in the ward, he was shifted to ICU because of the desaturation. And in the ICU, we took a routine ECG and surprisingly found out that he was going into an acute inferior myocardial infarction. Immediately, we thrombolized him and the ECG became normal. If he was in the ward, he would have died. So similar, many cases we have come across. And my colleagues from other colleges, they are also saying the same thing now. So first possibility, we discussed with the cardiologist also, first possibility is an acute coronary syndrome. The second possibility, with or without arrhythmias. Second possibility is definitely an acutely developing pulmonary myocarditis going into arrhythmia or whatever and die. And similarly, ischemia-induced LVF also we are seeing, especially in previous patients with the CVD. That is also we are seeing commonly.
Thank you. Thank you.
Now,
Dr. Jacob and Dr. Andrews, you have explained that every 4 hours you have to monitor the patient. In the first line management center with the hundreds of patients, how it is possible to monitor all these parameters in every 4 hours? So
in the FLTC, sir, in the FLTC, patients are either mostly asymptomatic or asymptom only. So they need not be followed actually every hour and hour. but they can be told to monitor themselves in the way they can report all the symptoms, and at least once or twice a day we can do, and maybe a walk test, especially symptoms. We have incidences where patient deteriorated in the home care or in FLTCs also. So that is why, because as I already mentioned, A and B are actually, according to me, most important group. 85% or 90% is A and B. So we have to somehow manage to, or make groups, or groups can monitor each other like that. Something has to be done, and this to an extent is efficiently being done. Not exactly probably every 4 hourly, but at least twice a day they have to be monitored. Plus SOS when they are developing.
Okay.
Okay, Jacob.
One minute. I mean, as Dr. Sabu has to leave, let him leave. And I thank you, Dr. Sabu Varghese, for his excellent topic.
Thank you everyone, because this is 12 o'clock here, in the noon, like noon time, so my patients are waiting since 11 o'clock.
Okay.
So
sorry
I am, thank you very much. Thank you.
Thank you, Dr. Sabu. Okay. Now, okay, thank you. Okay. Any more questions? It is getting late.
We are generally talking a lot about people not following the guidelines and being lax of late, particularly. But we have seen some people who are more anxious about this, and they even buy pulse oximeter at home and monitor oxygen saturation frequently. Do we have any guideline or evidence base to suggest this if they ask us?
ब्रेन में कुछ केमिकल चेंजेस आ रहे हैं, नस-नस में खून की रफ्तार. Dr. Jacob, unmute and talk. Dr. Jacob, unmute and talk.
As Dr. Sabu said, and I think we should have a facility for taking care of their emotional makeup. That is the problem. So that is either through telemedicine or WhatsApp or whatever. There should be a system. I think it is partly running. You can talk to these patients and comfort them, and I think there is no harm in buying a pulse oximeter. There are people who go in EMG and echo and things like that every time. It's very difficult to control them, but it's good at least they see pulse oximeter. But in our case, I think we are not having this possibility to go home at all. FLDC or the COVID hospital. So there it is not a problem. But in other districts, somebody is having the government special permission or something, and also like that, then they will.
What are the earliest signs of chest X-ray of lung involvement in COVID patients? Earliest sign.
Dr. Jacob,
can you hear me?
Dr. Jacob, hello. I think
he is left.
I think. Hello.
It's all over.
I think he has left the. Somehow we lost the connection. Anyway, now it is.
Dr. Joy, I will answer for Dr. Jacob. I will answer that question.
Okay.
The earliest change on X-ray chest is peripheral patchy infiltrates. Bilateral peripheral patchy infiltrates, or some ground glassing, which is classically described on CT. See, you can't see ground glass opacities on X-ray. So X-ray will show bilateral patchy peripheral infiltrates. That is to say that it will play around in the lateral thoracic wall, mostly in the lower lobe areas. Later, as the ARDS advances or the COVID pneumonia advances, the lesion becomes full covering more than 75% of the lung field. So the earliest sign is playing around infiltrates in the lateral thoracic wall, subpleural areas.
Now, how will you differentiate between the ARDS of common people and COVID ARDS?
Now the college is over there.
This is to me? Dr.
Yes.
Fatharuddin is speaking.
Yes,
Okay.
yes, it is you. It's you.
The ARDS, the classical ARDS usually does not begin as a patch. It comes all of a sudden on an X-ray, which is usually uniformly bilateral. So when the patient worsens, as the hypoxemia worsens, as the PF ratio, PaO to FaO2 ratio worsens, so there is a graded increase bilaterally uniformly, just like you see a consolidation or a bronchopneumonia. It will be uniform and it will not be specifically located on any particular anatomical segments or bronchopulmonary segments. It will be throughout from the right lower zone and mid zone, usually. But here in COVID, it begins invariably in the lateral zone, on the subpleural areas. And this you can see if the patient comes to you early. The first saturation time, if you take the X-ray, but the moment the patient saturates, first time if you take desaturate, that point if you take X-ray, you can see this. It begins and play around in the subpleural area. As the disease advances, then it will become full like the other ARDS. Radiologically.
Any more questions? We are getting late. Let us close the meeting. Hello? Hello?
One last question.
I mean, we are getting late now. Thank you, Dr. Sabu, Dr. Fatahudin, and Dr. Syamsunder, Dr. Jacob K. Jacob for your excellent talk.
Dr. Harun wants to ask a question.
No, not a question actually. It was very, very informative. I just wanted to say thank you. Sorry. Yep.
Thank you, Dr. Harun. Incidentally, Harun was my junior in my medical college. He's a neurosurgeon from Medical Trust. Anyway, let us close the meeting. Thank you all very much for your participation.
Thank you.
Dr. Pawan Madhusudan for vote of thanks. Pawan, over to you.
Thank you. Thank you.
Yes. Thank you, Dr. Joy, President, for conducting the CME. I especially thank the Vice Chancellor of KUHS, Dr. K. Mohanan, for inaugurating